welcome to the SBI Summer Series. Tonight's topic is Breast Imaging Toolbox, a discussion of newer emerging modalities. I'm Mitva Patel. I'm a breast imaging radiologist at OSU, and I'm going to be the moderator tonight. We have a great panel lined up. I'm really excited to talk about this topic and for you to meet the panelists. I think this is an important topic because many breast centers are considering adding a modality. There's been just an explosion of technology in the last 10 years, and it's not exactly clear which modality radiologists should be adding to their practice. Tomosynthesis and ultrasound is sort of the standard, as well as a full protocol breast MRI, but the consideration to add abbreviated protocol MR, contrast mammography, and screening ultrasound is a choice that some of the centers are trying to make. And we have panelists here who have an interest or expertise in these modalities that are going to share their experiences with you. Before you meet the panelists, just a little housekeeping. This is a series that's run by the SBI Social Media Committee. The summer series, today's topic is the last installment for 2021. We've had some great discussions this summer, topics on risk, breast density, COVID updates, breast biopsies, breast education, and breast fellowship. So if you've missed any of these talks, you can find them on the SBI Facebook page and also on the YouTube page. If you're watching this live, feel free to post any comments or questions, and we'll try to get to them. And if we don't, we will try to come back and answer them on Facebook after the broadcast. Okay, so let's meet our panelists. Kirti?
Yes. Hi, my name is Kirti Kulkarni. I'm a breast radiologist from University of Chicago. I'm an associate professor at the university. I've been there now for 10 years, long time. So I've seen the ups and downs of the breast section. I was trained in abdominal imaging and breast imaging. I did 2 fellowships, but in the last 3 years, I've been doing dedicated breast imaging. Yeah.
Great, thanks. Thanks for joining us. Matt?
Hey everyone, I'm Matt Miller. I am a breast imager at Allegheny Health Network in Pittsburgh, Pennsylvania. I did all of my medical training at West Virginia University in Morgantown. Yeah, excited to be back.
Thanks. Clayton?
Hi, I'm Clayton. I'm a breast imager at Ohio State University. My office is a couple doors down from Mitva's. Did a lot of my training at Ohio State. I help run our automated breast ultrasound screening program, and I also help run the imaging informatics division in our department.
Thanks. Welcome, Clayton. Amy?
Hi, my name is Amy Patel, and I am a breast radiologist. I'm medical director of the Breast Care Center at Liberty Hospital, which is in the Kansas City, Missouri area, and an assistant professor of radiology at the University of Missouri, Kansas City School of Medicine. Thanks for having me this evening.
Thanks for joining us. Katya.
Hi, good evening, everyone. Thank you for having me. I'm Katya Doddleson. I am a breast imager at Weill Cornell in New York. I did all of my radiology training, including a breast imaging fellowship at NYU, so just on the street, and stayed in the area. I'm an associate professor of radiology and a department lead of one of our breast imaging sites that is currently being built and developed.
Thanks. Pauline?
Hi, everybody. I am just like Kirti. I do breast and body imaging at Cooper University Hospital in Camden, New Jersey. I did my training across the river in Philadelphia at Pennsylvania Hospital and Jefferson Universities. And I am an associate professor at our medical school as well as run a med student clerkship and try to get more excited students to join the dark side. Happy to be here.
Thanks for joining us. Okay, so our first question is directed to all panelists. What modalities does your facility offer or is planning to add? And in what setting, is it the screening or diagnostic setting? And in what population do you offer that modality? Should we start, Kirti?
Sure. So we currently have expanded and we have 2 off-site locations, and we probably will have a few more in the coming years. So we do offer screening and diagnostic at all the locations, and we also offer MRIs, screening MRIs and diagnostic MRIs at one, which is the main campus, and currently are in the process of initiating MRIs at one of the other offsites as well. We do offer ABIS at the primary location, and we currently use SonoCine for our whole breast ultrasound screening, and have recently purchased this GE ABIS machine, and we're super excited. That will be offered at all the 3 sites, so that is something we're looking forward to. We are pretty much all TOMO, especially in the diagnostic and screening area. There are sometimes we do have 1 2D machines, and sometimes if there is a backup, we will do 2D screening and diagnostic as well. When it comes to MRI, we do offer abbreviated MRI screening, and also have tons of research studies going on, like the CAPS study and the Wisdom study, and the abbreviated MR study specifically for dense breast. So there's a ton of research opportunities as well.
So did you say you have ABIS and SonoCine for your screening ultrasound?
No, so we currently have the ultrasound SonoCine machine, which is an automated whole breast ultrasound machine, but we will be getting GE.
We'll be adding ABIS.
And that's what we're excited about. I've heard and I've seen images, and so SonoCine is like a single axial, it's like a robotic arm that goes over, so it's like a plethora of axial images that come back to back, but there is no reconstruction algorithm that is based at the back end. Whereas GE, I will hear from the experts, has a lot of that and higher sensitivity and specificity. So looking forward to that addition to our program.
Okay, great, thanks. Matt?
Sure. So we have at Allegheny Health Network, we have 4 central sites, we call it, that are mainly hospital-based, where we, offer the gamut of, screening mammograms, diagnostic mammograms, procedures, and whatnot. We have 1 site that offers ABUS, and we do handhelds at the other sites. I would say our volume with ABUS has increased over the last year since I've been here, just because we've had more of an outreach to the surgeons and clinicians about the importance of supplemental screening. We offer MRI at the 4 central sites as well. We have community sites that, varying degrees of diagnostic workups can be done. A few of the community sites do diags, a few of them do procedures. But at the 4 main clinical sites is where we do the majority of our meat and potato breast imaging. We offer MRI at the 4 main clinical sites as well, the 4 central sites. Full MRI. We are in the process of developing abbreviated MRI in our system, but have not quite crossed the finish line yet. And interested to talk about that with those who have crossed the finish line.
Yeah, well, others can probably learn from some of the things that you're doing, or maybe some bumps in the road that you've had, and also interested in how you compare ABUS and handheld, and we'll get to that in a bit. Clayton, can you tell us about OSU?
Yeah, we have a series of diagnostic sites where we do mammography and handheld ultrasound screening and diagnostics, and then we have multiple additional sites where we just do screening mammography. We have TOMO modalities everywhere. Our TOMO utilization rate seems to be plateaued in the 80% range or something about that. We also have a couple of ABUS machines. We have GE and Vinia machines, and those are at a couple of our outpatient sites where we do them screening, offline reading only. And then as far as contrast mammo, we do that at one of our central sites, our main site. And we do that for diagnostic use only at this point. And it's kind of been hard, I think, to get some traction there. Mitva can talk about that much better than I can. But we've been successful, but I think it's been hard to get beyond that initial phase where we're using it infrequently to where it becomes a standard part of our practice. And then as far as MR, we're sounds like right behind where Matt is. We're kind of in the contemplative phase of abbreviated MRI. So we just do full protocols for screening and diagnostic, but I guess we kind of wish we were a step or two ahead of where we are. So same as you, eager to hear what others are doing.
Great, thanks. Amy. Amy? Maybe she can't.
Amy, can you hear us?
Frozen.
She looks frozen to me.
Let's go to Katya, and then we'll swing back to Amy.
Hi, yes. So we have multiple sites, all of which offer both screening and diagnostic imaging. And we're actually building out and expanding more, as many of us are, to meet the demand, which is fantastic. All of them, as Kirti mentioned, we heavily offer tomosynthesis both for screening and diagnostic. So it's utilized pretty consistently for all our patient populations. We do screening ultrasounds. We used to use automated, and now we're doing handheld, and we do quite a significant volume of screening handheld ultrasounds with dedicated sonographers. Our breast MRI, we do both screening and diagnostic. We have a very high volume at all of our sites, and which also obviously we are offering MR guided procedures as well to go along with it. And we are sort of in between Clayton and Matt, where we're contemplating very aggressively and implementing abbreviated protocol, in particular as we're building up our high-risk population, high-risk screening. And I feel like certainly some of the pressures of the pandemic and trying to optimize timing and spacing out of patients have driven us to this more aggressive phase. Great.
Pauline?
Hi. So we also have multiple sites, just like everyone else. We are essentially all tomo on our screenings. We do not do ABUS. We're all handheld ultrasound, and we're mainly Philips-based for our ultrasound machines. So curious to hear about GE and some of the other equipment that others are using. We only have one GE machine, and that's by accident. Sort of, it was delivered to the general room, and ours went down. So it's currently one of our biopsy machines. But it's tough sometimes when you take patients in the Philips room and then you bring them to GE room, and it really makes a difference. And it's a huge difference. So equipment standardization we feel very strongly about. We do have MRI. We do not offer abbreviated protocol. We do the same protocol for everyone, screening and diagnostic. And we've been using contrast enhanced mammography since 2012, pretty much as soon as it was implemented and approved in 2011. We've been fortunate to be one of the GE sites and had tremendous experience. And Clayton, to your point, one of the reasons we were successful is we had a strong buy-in from our surgical team. And I would say that in the beginning there was a lot of enthusiasm, but at this point it just comes in as a routine study, and we use it for screening and diagnostic purposes. We have a dense breast clinic, and a lot of our EPNs who see patients in the dense breast clinic who perhaps do not qualify for the MRI in their screening numbers will get a screening CSM.
That's great.
And we do a full complement of procedures. Obviously, to go along with the other modalities.
Amy?
Sorry for my unstable internet connection. It's like the best laid plans. I've participated in this summer series before and no issues. But so when it comes to screening, obviously we're doing digital breast tomosynthesis like everybody. I think it's safe to say now that although it's known as supplemental, it's really sort of our first line now when it comes to
Standard of care, yeah.
Yeah, and then, we do particularly screening ultrasound handheld. We don't do automated, particularly for women who are at high risk. So we do not currently screen average risk women with dense breasts, but we do for those who are high risk. We also offer, of course, breast MRI, and we are gearing up to offer abbreviated MRI. So, and of course, everything that complements biopsy-wise for all of those. I had some experience in my old practice with interpreting abbreviated MRI and being involved, and so I'm excited to get to implement this now in my current practice.
That's great. Thanks. So it sounds like everybody's got sort of a mix of some additional modalities on top of, like we said, the standard seems to be tomosynthesis, full protocol MRI, and diagnostic ultrasound. But for some of these additional modalities, and I'm talking about screening ultrasound, whether it's ABUS or handheld, contrast mammo, or abbreviated protocol MR, how did you make that decision to add that particular modality, or what would you tell other centers to evaluate before considering one or the other?
So I can talk about abbreviated MR as far as why we made the decision. So I think in breast imaging as a whole, you have two competing modalities: abbreviated MR, contrast enhanced mammography. They kind of exist in the same utility, but different functionality as far as workflow and whatnot. The reason our practice decided on abbreviated MR when we're trying to figure out, okay, what's the next step? Every breast imaging center has MRI capabilities, right? If you're MQSA certified, it's already set up. You already have that infrastructure. And so you're basically just changing and actually improving the workflow of breast MRI, making it a little bit easier to do those studies, assuming that you can take some of the people who may have got the full MRI and bring them down to a shorter study time. So that was kind of the rationale between doing abbreviated MRI. That plus sometimes I know that contrast enhanced mammography is getting better, and I'm excited about it. I've never actually interpreted one, but there are times when if you can't, there are problems with biopsies with contrast enhanced mammography. What do? You send them to do an MRI. So that was kind of where our practice lined up with abbreviated MRI.
So you were looking at the physiologic studies that we have, contrast mammo and MR, and between those two, a negative was the inability to do biopsies on contrast mammo and just the implementation hurdles that I'm sure we'll talk about with contrast mammo. Yeah, those are good points.
But to balance what Matt was saying, if I may jump in, the abbreviated MRI takes about 10 minutes or so, and so does contrast mammography, offering very similar information for those of us who have experience with it, but offering you a different opportunity to look at things, particularly for patients who cannot undergo MRI.
Sure.
Contrast mammography offers you a great opportunity to get very similar information. And it's a great addition to having extra tools in your box, since we're talking about Toolbox, to offer this to our patients. So just as a counterbalance here.
Yeah.
Anybody else on how they decided to add, particularly ultrasound maybe?
Yeah, I would like to jump in. So we have had SonoCine now for probably 6-7 years. And we were having struggles with just the way the machine had some technical issues. The transducer wouldn't detect. There were some water artifacts. And we would keep trying to get things fixed here and there, but just overall thought that the image quality was deteriorating over time. And also we felt that not having the 3D reconstruction algorithm was sort of a miss. So when we call the patient back for, say, additional workup, it was harder. There were times when we couldn't reproduce the lesion, or there were times when it was just overlapping tissue. But I felt that our cancer detection was also not at par. I'm glad we made this decision to go ahead with GE. Invenia seems like a robust machine. And given that we have these multiple offsites, all the offsites will be having the machine. Now that makes it really helpful because we do in Illinois have the density law passed, and we do encourage our patients to get adjunct screening. We put it as a disclaimer in our report, and it would not be fair if our offsites don't offer it. Also, we have a very strong working relationship with our basic science, the physicists and basic science research group, and a lot of them have invested a lot of time in working on ultrafast sequence, and we use ultrafast sequence as a part of our full protocol, as well as part of our as part of our abbreviated sequence as well. And that has been exciting. It's just something that we kind of are now used to. And we realized that adding that additional layer of ultrafast to the abbreviated MR sequence made us feel more confident. You can get some kinetic information, which otherwise you probably are lacking when you're looking at a regular abbreviated MRI, which kind of was introduced in 2014 by Dr. Cool. But yeah, so some of the processes behind our decisions.
That's interesting. There was a question that popped up on dedicated breast CT, which I admittedly don't have any experience on. I don't know whether anybody else does. We have not chosen to add that to our practice. I feel like already it's sort of a crowded field in terms of what we're going to offer. And so that hasn't really been in the mix for us. Has anybody else thought about adding dedicated breast CT?
No.
I mean, CT does have a role in breast cancer detection in that there are people that get chest CTs for lung cancer screening and whatnot. Don't ignore the breasts. I mean, we can detect breast cancer on CTs, but we don't routinely do dedicated breast CTs for cancer detection in the breast.
Yeah, absolutely. I agree. I mean, I think that given what has been mentioned here earlier about MRI and certainly its resolution and its sensitivity, the potential of CT as a dedicated modality for our breast imaging is definitely lacking. So if one is going to do any three-dimensional modality, MRI would certainly and has been shown to surpass it. Certainly in the setting of PET CT, I know there's a lot of, you similarly as during lung cancer screening, you can detect and see increased FDG uptake, and that might lead you down the road of more dedicated breast imaging. But I don't think that that's certainly where the most optimal tool.
Yeah.
Let's talk a little bit about screening breast ultrasound. The diagnostic performance of automated ultrasound versus handheld ultrasound is similar. How do centers make the decision of one versus the other? And if you chose handheld, how do you make the decision to have it done by technologists or physicians?
I think that's a great question. I can jump in there because we had the experience of both and pretty, Kirti, you guys have a fantastic, obviously, experience with automated ultrasound and love it. We had a very violent reaction to it. And I think the reason is sort of where you stand. We are very fortunate to have a very fantastic team of dedicated breast imaging sonographers. And so to trade in automated ultrasounds that for a practice that does a significant volume of screening ultrasounds, which we do similar to Illinois, we have a density law that requires patients to be informed of their density and the utility of additional potential screening. And in addition, New York does not require copays for insurance copays for additional imaging or screening modalities. Specifically, ultrasound as such, our population's quite large. Also, just based on the density distribution of our patients, they tend to be on the heterogeneously dense and extremely, it's not a normal distribution in our practice like it is supposed to be. And so we're definitely skewed toward the denser breast population. As such, many of our patients choose to undergo together in a decision with their physicians to undergo screening ultrasounds. And so the volume is quite large. We have fantastic technologists. And so when we did switch to automated ultrasounds, it takes about 4 seconds to read a negative screening ultrasound, those 12 images or however many you're going to choose in your practice as a practice to document, versus going through even a negative automated ultrasound. That's about a couple of minutes time. And so that probably is what very much drove our decision to go back to handheld. And it's certainly done by technologists, again, because we are privileged to have dedicated breast trained technologists, and our volume is so high that it would just be prohibitive for our physicians to be able to do it. We certainly check anything that is, as I'm sure we all do, in question. And we do offer a same-day screening practice, and we we stopped for a while during COVID, and we're back to offering our patients same day reading of their screening mammograms to give results. And if there's a question, something on their screening ultrasound, we will go in, the physicians will go in and double check. But routinely, it's the technologists that do that. It's purely logistically driven.
So Katya, just to understand, so you do same day screening mammogram and ultrasound results? I mean, pre-COVID, you used to give both?
Yeah. So yeah, any patient who is presenting for screening, whether it's a unattached screening mammogram or a screening mammogram and ultrasound, if they choose and want to be read, if it's during physician hours, which are now expanding and much longer, then they get the results right away. And if they need to be converted, certainly we'll do their diagnostic workup then. We usually don't have the capacity to add on biopsies should one be needed same day, but otherwise we will do the entire workup if it needs to be done that day.
Yeah, that's interesting. Clayton, do you want to share with us how we decided to do ABUS?
Absolutely. Yeah, I think like the things that you mentioned are like key. The state that you practice in is going to really determine what the best supplemental choice is. And I think ultimately how successful you're going to be. At the end of the day, the out-of-pocket expenses are really going to drive a lot of patients' decision-making. For example, in our state, Ohio, tomosynthesis isn't required to be covered. So although it is covered at a high rate, it's not covered at 100%. So that's an example of a barrier. We have a breast density notification law, but there's no requirement for coverage, and there's no requirement for coverage for MRI. So, you know, for us, there's this happy island of coverage for mammography, and then it gets a little blurrier for tomo, and then a little worse for ultrasound and MRI. But that's different everywhere, right? It's very heterogeneous. So that's like the most important thing, I think. But then you made a really excellent additional point, which is you kind of have to decide, like, are you a batch offline reading site? Is that how you envision your supplemental screening being, or is it online? And then I think that combined with the quality of your technologists and your practice pattern, do you back scan a lot? Are you the primary scanner as the radiologist? I think those things kind of all come into play. So I told you a little bit about our practice, but our goal was to have these available to be batch read, and that's how we do our screening. And so we even positioned our ultrasound, our ABUS machines off sites. So there's no pressure for us where they're not even staffed by radiologists. There's no question that we can read them in real time. And so we read them quickly, but it's not in real time. And so that has been a benefit for us for staffing purposes. And to your point, they can take 4, 5, 6 minutes to read. Sometimes even longer. And so it's not feasible to just hammer through them. It would be sickening to have a list of like 50 of them to try to read. So those are some of the things. I do think that there's some advantages with the fact that the physician is presented with the entire volume of both breasts. And that advantage grows the second year that you do it, because if there's something you have a question on, you do the same thing you would do with a mammogram. The first thing you do is you look at the previous year's study. And so, you know, that's an advantage. It is a lot of work to look back, but that's an advantage. I think that the other thing is that you're just giving the radiologist the chance to react to everything that's there, and then a chance to like kind of leisurely ask someone else for help, another set of eyes, and to compare to a prior MRI or a CT or a mammogram to kind of like work your way out of it. So those are the things that I think kind of are slight advantages. I think a disadvantage of automated breast ultrasound is at least GE's system requires like a specialized viewer.
Yep.
And so the IT part of me kind of cringes when we went through that. So we jumped through a ton of hoops to make it so every radiologist could read every study all the time, because that's not the default configuration, because we didn't want to have like the ABUS guy or girl, and then like they're on an island, right? They can't seek help from anyone else. And so that was something that we kind of avoided, but I think that is a potential pitfall for automated breast ultrasound.
I can speak to that. I mean, we struggle with that because, you know, we actually we're blessed to have actually home breast workstations, and with our ABUS volume picking up, it's like, can we get the ABUS software on our home workstation so we can? Because I mean, sometimes I'll have a screener day from my house, and I'll help people who are on site and pick up all the MR and pick up a bunch of MRs. You know
So
what I mean?
Matt works at Allegheny General Hospital. Yeah,
What's that?
you work for Allegheny General
That's
Hospital.
amazing. Yeah.
It's
Way to
nice.
go.
It's right behind this camera right here. Is my mammo monitor.
You're making us all jealous, Matt. That's crazy.
I know.
It's nice, but no, I mean, I can speak to that from the standpoint of it's very limiting when you can only read a bus from a bus stations. You know what I mean? Dedicated a bus stations, and they actually charge you per station. I mean, it's like give me a break here. I can kind of speak from where I was before I came to AHN. I was there when they set up their a bus. And I remember as a resident, them talking about, okay, this is going to be a big thing. This A-bus thing is going to be a big thing because it's going to take the inter-user variability out of the equation. It's going to be, person's going to come in and they're going to get the same ultrasound study every single year. It's going to be better than handheld. I mean, this was before all the, the big time research had been done on it that showed there's really no difference in cancer detection. So that was why A-bus got set up down there at my former place of training at WVU. And so no inter-user variability. Hopefully it's the kind of the new biggest and best thing. Now, I mean, in practice, like Katya says, it's absolutely wonderful when you get that normal screening ultrasound. You can read it in 10 seconds and be done with it. Whereas A-bus, it takes so much time to load it up, make sure you're on the right computer. There's been times I've seen an A-bus on the list and oh, wait a minute. No, I'm not sitting at the A-bus computer. You know what I mean? It's like, so I like A-bus. I like reading. I think the images are cool. It's a 3-dimensional image of ultrasound. I enjoy it. I mean, I've caught cancers on it. I think it works. But it may be more cumbersome than it's worth when you have to have, quality ultrasound techs. You have to be able to trust your techs that are doing the handheld. That's the other side of the coin too.
I think that's the biggest point. I absolutely agree. And I think in practices and in maybe areas where there's a dearth of even breast radiologists, fellowship trained, and you're trying to accomplish a large volume and really serve the patients, having A-bus would be useful because you're able to certainly allow access to screening ultrasounds to a larger portion of patients, but where you do have the luxury of dedicated technologists, it's really hard to argue.
Mm-hmm.
Amy and Pauline, you both said that you have handheld ultrasound. Was it hard to make the decision of technologist versus physician, or is it a time management thing? Or can you tell us a little bit about how you make that decision?
So we're fortunate to have amazing technologists. Sounds like we're all in the same position, which is a luxury because we see ultrasounds come in. I'm like, oh my God, who did this ultrasound? I can critique it till tomorrow. But we're so fortunate to have amazing technologists who are my eyes. They're my eyes, my hands. And in a busy practice, I backscan a lot for my own visual because if I read the screening, just like Katya, same day screening mammogram, and I see something and I want to know exactly what that thing is that's been there for 10 years and no one said anything about it, I'll put my probe down and I'll find out exactly what it is and close that chapter. But in a busy practice, you can't really screen everyone. And these days in New Jersey, we now do a lot of screening ultrasounds because it is covered by the insurance. And so our screening volume has skyrocketed. Almost every ultrasound that our technologists do ends up being a screening ultrasound, in addition to perhaps some diagnostic component of it. So it's so busy that we just continue with our current practice. And I guess we just never crossed the bridge into the A-bus world. We just, at this point, I wouldn't even have space to put it into. Just so busy.
Let's move on to MR.
Can I add something?
Oh yeah, sure, of course.
So, we are at the academic institution, always took pride in doing our own ultrasounds, and now are hurting because, it's the volume's gone up, the number of radiologists have gone down, and you are doing your callback ultrasounds. We don't do whole breast screening ultrasounds because those go to our Sonographers machine, but second look ultrasounds. There are still a ton of ultrasounds that happen in the breast world, and And now we've realized that we really need to find a technology that would.
You do all of your ultrasounds?
Yeah, we do all of our
wow.
ultrasounds. And now we're in this, and we took pride in doing that all these years, but now I've realized with the increasing volumes and especially we would still want to keep doing the MR second look ultrasounds, but really want technologists to do the bread and butter ultrasounds. So yeah, we are now, that's another decision-making process that we finally have come to terms with and decided that we want a sonographer, a breast sonographer, trained sonographer to be part of our team. And we look forward to that transition.
So for a scenario like that, it almost makes sense to get the A-bus machine rather than try to search for staffing and people that are comfortable to do all these screening ultrasounds.
Right.
We've had pretty good luck training mammography techs. It does seem like it's pretty, like the learning curve is pretty short for the GE system, but I think the inverse is also true. We have some like fantastic ultrasound techs who are running the A-bus machine some days, and it practically feels like a crime because they're so good at handheld ultrasound, and their resources they're not being utilized while doing the automated breast ultrasound.
And I think it helps with the workflow as well, right? Like one of the attending has to go do the ultrasound while on the side is looking at some other cases and then come back and let that patient go. Whereas if there's a technologist involved, I think it definitely helps with the workflow. We do have a resident usually and a fellow who's rotating, but still it's a difference when you have a technologist involved, because that way the fellow could see all the cases, and if the fellow is doing ultrasound, doesn't have to miss any.
Absolutely. So I think we lost our moderator, the connection, but I can kind of sub in. So we wanted to everyone's good on abbreviated or on A-bus, right? Is there anybody that wants to say anything else about that? We covered that. We want to make sure we cover the other stuff too. Talking about breast MRI.
I would just quickly jump in and say that, and this could be an unpopular opinion, but one of the main reasons why we didn't go with A-bus was we just don't like the image quality of it. We feel that our technologists, and again, we are blessed as well to have very skilled breast sonographers. They are cross-trained in mammography technology and ultrasound. So they are just dynamic and incredible humans that we rely on, and they just provide very beautiful images. So from a workflow standpoint, especially right now we're short-staffed, we'd love to go in and scan all these patients. It's difficult. So having that really incredible sonographer being there to do a handheld, to get through the images in a very efficient manner is imperative. And I think regardless of whether you're in private practice or academic, we can all agree that we are in a increasing time crunch. I think our volumes are just exploding. So, we really try to optimize practice efficiency for us, that sort of model works.
But I do think that there's, because I agree with you entirely. You have a great sonographer, they see a lesion and then they kind of like have in their mind what they're going to show you, right? That's why they're so good, and that's why the images are so excellent. I do think that the A-bus technology can work well if the mindset is just it's abnormal or it's normal. And then using handheld, you bring the patient back to evaluate an area of concern there. Because I think it's kind of a different question than like the most beautiful handheld ultrasound image. But I completely agree, like a normal handheld ultrasound versus an A-bus, I'll take 5 of one versus the other. The one advantage, though, I do think is if you can structure your program either way, whatever it is, to allow for batch reading. I think that as you think of staffing and accommodating additional studies and your capacity as a center, I think it's not just the time it takes to read the study, but it's basically the urgency and the flexibility with which you can read it that really drives a lot of decisions too.
Absolutely.
Just to add, there's a side question about how you train your sonographers. We've been very successful in training a lot of sonographers. Obviously, they're first and foremost sonographers, so they know what to do with ultrasound. But if they sit with you and see the mammography side of it, then they become really versed in correlating what's on the mammogram and ultrasound. And yes, we can point to them and give them GPS coordinates of what to look for. But when they're essentially independent practicing doing the entire screening ultrasound, they have to be able to correlate what's on the imaging on mammography to make sure that they identify the same structures on the ultrasound. So it takes a certain mindset and desire to learn and eagerness to be able to do that. And we've been quite successful in training sonographers to do that, and we rely on them heavily.
It helps when you have a radiology technician school associated with, you know what I mean? So you can kind of feed into your own people.
Absolutely. That is totally what we do. And it's been fantastically successful. And as you said, you know, it's a pretty short learning curve if you're, as Pauline also mentioned, if you have the mindset and curious and want to learn. And so having them rotate with us sort of from the beginning, so they're not, don't learn bad habits and are curious enough where they get into practice of reviewing the mammograms with us. And we're not just saying, you know, listen, just look from, 4 to 5 o'clock, middle depth, but rather this is what I'm looking for and this is what it looks like. And that makes all the difference in the world.
Right. Yep. And taking it to the next level, once you identify small cancer, making sure we screen our axilla routinely, especially in someone who we think might have metastatic disease. So by the time I get to the ultrasound, sonographer has already
looked at.
It's already done. I already know that there is an index lesion, there is a satellite lesion, and a metastatic lymph node. And that's what training of our sonographers is all about.
Yep, absolutely.
Absolutely. But I think, as was mentioned before, we are, this is definitely changing times and evolving times, and and we need to stay dynamic. And some of these modalities may be useful at certain times in certain areas, in certain context. We're debating pros and cons here from a position relatively of privilege. So I think that's something to remember about a lot of sites across the country and across the world too.
Definitely. Well, that's a good segue into, let's start talking about MRI a little bit. And Kirti, I think you're the only panelist here that has an actually established abbreviated MRI system at your practice. We had a few questions about abbreviated MRI. One, talk a little bit about the sequences that are used, and two, what time slots you give for. So we know that on average, abbreviated MRI is supposed to take less than 10 minutes, right? Do you give it just a 15-minute time slot for MRI scheduling? That was just a question that was asked.
Sure. There's no doubt breast MRI currently is the most sensitive imaging tool to detect cancer, regardless of the stage or type of cancer, regardless of the breast density. I think it has definitely outperformed mammography, tomo, and ultrasound. There are tons of, the most recent trial was the ecogacrin EA1141 trial that people are aware of. I mean, abbreviated MRI was introduced by Christiana Kuhl in 2014. That was the first paper that I remember reading about, and it's definitely evolved over time. At our institution, back to your question, we typically have our time slots, MRI time slots for 20 minutes. And our regular full protocol MRI sequence is also less than 17 minutes. Actually, it's up to 15 minutes. Wow. We're pretty good at teasing and tweaking it in such a way that our full protocol MR takes 15 minutes. We also, like I mentioned earlier, add—
That's fast. Someone call that abbreviated.
Our full protocol is pretty good, and our abbreviated MRI is down to close to 5 to 7 minutes. Wow. We have an ultra-fast sequence that we use, and we really take pride in looking at our ultra-fast sequence, and we do it even when we are looking at our full protocol, and we also use it with our abbreviated MR protocol. I think the advantage, according to me, is that ultra-fast sequence gives that little bit of features that abbreviated MR has a question mark about. Like usually the early onset or the early enhancement is what we're essentially looking for and should be enough to characterize most of the breast lesions. But when it comes to, say, a lot of BPE, and you want to differentiate the BPE from the actual extent of the tumor, then those are the areas where I feel ultrafast gives me that extra confidence.
Sure.
There are a couple of quantitative measures that we typically use, the time to enhancement, and we look at the slope. Those are the certain things that we look on the kinetic graph and use that to include or exclude that area as cancer. Our experience with abbreviated MRI has been fantastic. We currently have, like I mentioned, have a great, strong relationship with our basic science group. And I think that kudos to them, especially Dr. Greg Karsmar, who has been involved with and his research team who's been involved with including ultrafast sequence and preparing the exam card, making sure that any tweaking, anything that we do, the technologists know about it and make sure they use the right study, the protocoling piece. We have it down now, just so no wrong study gets done, especially because we are doing a lot of other research studies, like the CAP studies going on, the Dodorum study. There are multiple other research studies going on, so we don't want to do the wrong study on the wrong patient. Back to abbreviated MRI. I mean, the usual full protocol MRI was first recommended for women with high lifetime risk. There was no doubt, and even was introduced for intermediate lifetime risk as a screening tool. And I think what we always want to use MR, the major advantage I see is the fact that it improves the detection of biologically relevant cancers, right? I mean, the whole idea being that we want to find cancers that matter, cancers with active angiogenic activity. And I think that's why I feel that it's still very debatable as to can we use abbreviated MRI in the average risk population or not? Could there be a mammogram and a adjunct screening with an abbreviated MRI? That might be a good tailored approach for an average risk person. That is another thought to be considered. We recently had applied for a SPORE grant where we did include the idea of using abbreviated MRI 6 months and then a full protocol MRI at 1 year, just to see how would that be used, especially for someone who is as an average risk. And I feel we got a lot of feedbacks from the reviewers that, in high-risk women, this was for high-risk women, and things are still under investigation. There are still a lot of research done. So currently, it wasn't something that was accepted right away.
So thank you. That was a fantastic overview of how you guys are implementing it. What in practice? So you're talking about doing some research and figuring out this is all kind of moving parts. This is why it's emerging topics in breast imaging, right? What are you currently what patient population are you currently using your abbreviated MRI specifically for right now? Like, do you have a dedicated schedule for the certain patient population?
So anytime we have a category C or D breast density in our screening report, we have our team of the schedulers. I was trying to find the word. Thanks, Matt. Who would go through those reports and then contact the patients and talk about the idea of getting an abbreviated MRI. We also have a CPT code for the research component of the abbreviated MRI. So it definitely helps us with the billing purpose as well. And also, I feel, given that we're on the south side of Chicago, we use this more for an outreach as well, because we have done tons of outreach programs where we've gone to the south side of Chicago, targeted a church specifically, and then spoken about the density and about category C and D breast density, and what are the tools that we offer, and how would this test be helpful, etc. So,
so you use density to drive your patient population for fast MR and not risk.
That's right, because I think for the high-risk women, there's still some concerns of will abbreviated MRI be enough. Maybe
Sure.
there could be an abbreviated MRI with a full protocol MR, or could there be something more than, because calcifications, of course, you're not going to see, and we feel confident. It's
Sure.
not far away where we will feel confident because of the addition of ultrafast sequence, that along with ultrafast and abbreviated MRI, we have a great tool in itself that we don't even need the full protocol MR. And the interpretation time is low, the cost is low. The MIP image, you literally can skim in 3 seconds, like Dr. Cole says, and then when you want to dig in deeper, you then can go through. And we use DynaCAD for all our post-processing sequences, which has been just wonderful tool. I agree with you, Matt, that DynaCAD was like that, where you had to work on that workstation. It's like in Kenya where you couldn't really, but now things have changed and you can have DynaCAD as a
DynaCAD's opened it up a little bit more. That's what we're hoping ABUS does. So
Just
thank
curious,
you for that. What's
sorry,
that?
Matt, just curious for the other panelists. It sounds like Curdy's regular MRI is my idea of abbreviated MRI.
Oh, I know, exactly, right?
How long are your studies for the other panelists, please?
40 minutes, 45 minutes.
I agree. We worked really hard to get it down to like 22 minutes, and we were so proud of our full protocol. It was we were crying as we were getting rid of sequences and down, and it was so emotional, but we got it down and it was great. And now, you're putting us to shame, Kurt.
Yeah, that's awesome. I want to add on to the thought that Curdy was talking about, or that we were kind of discussing with the patient population, and density versus risk versus using them together to kind of develop a niche for abbreviated MRI. Let's compare that and maybe contrast that to those of you that have had a contrast enhanced mammo program set up. Can those of you, because we don't have that in my organization.
So our contrast mammo from start to finish, from the start of the injection to the finish, is less than 10 minutes. Ideally, we want to make it under 10. In theory, it's about, in general, it's about 7 to 8 minutes of all of the imaging completed from the start of injection to the end of injection. And we review all of the images immediately on the spot before the patient even leaves the room to guide the ultrasound evaluation to increase the yield, because our GE contrast mammography is a bit old. Like I said, we've had it since 2012. So in order for us to have capabilities of the biopsy, we try really hard to locate the target on the ultrasound. And we're successful, I would say, in about 80% of the time, and 80, maybe 85. And in the few that we're not, then we send them to MR. So we complete everything and review everything pretty much under 10 minutes.
That's awesome. So you just use it on diagnostic though, right?
No, we do use it in the screening setting.
You do?
In the patients who come through the dense breast clinic, or the patients who perhaps are high risk and do not qualify the MRI. And there will be times where they alternate with contrast mammography 1 year and tomo another year, just on alternating with ultrasound thrown in the mix both years.
I actually have a question, because this was fascinating, Kurt. Thank you so much for sharing the experience of your practice with abbreviated MRI. How, you in particular mentioned, south side of Chicago. How are patients able to pay for abbreviated MRI? Is that being covered by insurance? Because with ACR programs criteria, certainly that is not an indication that's as high as for high risk screening, which 20% lifetime risk of breast cancer, where certainly an MRI is indicated. Most insurances are forced to pay for that $4,000 study. But what about the abbreviated for average risk women with dense breast versus the cost of $300, $400 for a screening ultrasound?
Right. That is definitely the struggle that we're trying to answer. And at this point, given that we want more patients to go through the research trial rather than having to, pay or paid through the insurance. Currently, we are offering only as part of research, but the time is going to come very soon where we will be offering it as part of insurance as well. Currently, there is no, that I know, there might be some recent news, but I don't think so. There is a formal CPT code for us to bill for abbreviated MRI only. And once that is available, or if there is available, please let me know, because that would be the way we would be using for billing the patients. So I think part of it is also the communication piece, and we make it very very important. We think it's important for our patients as well as our physicians, so our surgery team to know, and our referring physicians, what does CND mean and what other things can we do for these patients. So even our disclaimer says adjunct screening with whole breast ultrasound or MRI. So there are some patients who read this and then call right away and say, tell me more about it. How can I get this information? Where can I get this information? So we have some brochures in the screening area that people can have access to. But besides that, we're trying to clean up the website. I have this new hat that I'm wearing, which is Vice Chair of Communications for the Department of Radiology. And that is very exciting because I'm trying to focus on cleaning up the website, making sure most of the information is available on it for patients, making sure there are brochures and pamphlets and things that could be accessible through QR code that are available at different clinics. So this is one of the tasks that we're trying to fulfill, where we can communicate through Epic to our providers and tell them about the study. And then come our schedulers and the research team who are on top of it, because they would call and see if we can fit in a patient for the dense breast study. And I think adding that ultra fast, which is a 45-second sequence, which has a temporal resolution of 3 seconds, which is fantastic temporal resolution, and we fit that in within that first minute, within that first time point. So we get like 2 data points to look at.
That's fantastic and so promising. Thank you for doing that and driving those studies, because I mean, obviously the sensitivity is superior, and certainly superior to an ultrasound. And if we can continue to show that and then drive the insurance companies to reimburse for that, that would be fantastic added value.
Game changer.
Right? Absolutely. And I mean, and also I personally think that that's certainly the way that, well, we should, and I think we are moving. And one of the benefits, ultimately, hopefully, with an MRI is sort of the longer protective screening interval that it will allow. One of the studies from Christiane Kuhl certainly showed that, we may not need to screen yearly if you're doing it with an MRI due to its protective effect, because it takes so many more years for something to develop. If there was truly no enhancement, it's not biologically active. So, that might be truly the evolving toolkit.
Well, and that's a great, almost a capper on this discussion, right? I mean, we've talked about all these different modalities. Where do you guys see breast imaging in the future with all these different modalities? Do you think, because right now we're kind of in this, contrast enhanced mammo versus abbreviated MR. There's even something that we didn't even talk about, nuclear medicine, radio tracer imaging. Yes. That has a role in there somewhere. Where do you guys see this all leading? And, today it's crystal ball, give a guess. Obviously, it is recorded, but you're not under oath. Where 10 years from now, where do you see these modalities being?
I don't think there's going to be one pathway. I think it's really going to be dependent where you practice. Yep. So I used to practice in Boston, Massachusetts. I had experience with both abbreviated MRI, contrast enhanced mammography. Now I'm in a completely different practice setting where although heading up a breast center in the suburban area, I oversee breast imaging for 8 rural hospitals in Northwest Missouri. And things like contrast enhanced mammography can be incredibly difficult to implement, particularly if you don't have a radiologist that's on site all the time. We have to keep in mind that although we are very blessed to have incredible institutions and practices around the country, oftentimes in many states, a lot of these smaller critical access care hospitals, their imaging is being read perhaps by a practice in, for example, we have many hospitals in southern Missouri that their radiology is interpreted by practices in Nevada and Texas. I mean, all over the country. So I don't think there's going to be a one-size-fits-all approach. I think what will be important for us is for us as a breast imaging community to be accountable, to know what works in your practice setting, and especially if you are touching particularly a site that needs access, to try to figure out ways for those patients to have access, because again, it just isn't a one-size-fits-all approach, and there's so many layers to this.
Yeah, and I think we have a responsibility to add to what Amy mentioned, is to, as we advance in our technologies, which are, they truly are demonstrating added benefit, I think we need to work as a community in order to distribute it to and allow access to the entire patient population, so that we are not the ones that are augmenting, you know, healthcare disparities, rather playing a role in minimizing and mitigating those.
Mm-hmm.
Very true.
Yeah, I think that's great. It's great words of wisdom. I mean, and that's really where our value as breast imagers lie, right? Being able to, you know, have these discussions and have these, you know, brainstorming things about, okay, this might work at this site, but this won't work at this. I personally think that, you know, some people have said that abbreviated MR might, you know, make the mammogram obsolete. Sure. I mean, there might be, you know, updated guidelines and whatnot. I still think that there's going to be a role for mammo, you know, for the foreseeable future into, you know, probably our late careers. You know, I don't think that it's getting replaced or anytime soon. I definitely think the utility of mammo is here to stay.
Well, there will be a Star Trek version where you slide the zapper over the patient. And
Iron Man, it's going to be 3D. You're going to be able to like.
We'll also make Earl Grey hot.
Yeah. Absolutely. Well, we're at our hour time limit.
Matt, I got a text message from Mitva that her power went out.
Oh my goodness.
I know.
Well, we definitely miss her. This whole session was her idea and was organized by her. So kudos to her. Hopefully she can rewatch this and see what she missed. I just want to thank you all for joining us. This is the second year for the SBI Summer Series. Everyone who's watching via YouTube or Facebook, thank you for coming along with the ride. Hopefully we'll be back next summer with a new exciting list of topics. And yeah, any other closing words from anybody?
If anyone wants to start an abbreviated or ultra-fast sequence, just send me an email and we'll chat more.
Sounds perfect. Thank you.
Thank you for inviting me.
Thank you.
Thanks, everyone.
Thank you.